So I'm back to pencil and paper, and something that's kind of novel, so I hope you'll look at me instead of the beautiful slides there. We had a really exciting session, a very broad-ranging session, and our topic was the evaluation and evidentiary requirements that needed to be addressed. And according to Tominaga-san this morning, we saw this hierarchy of evidentiary requirements, the technical requirements, and then interpretation. We kind of used that as a guide for our discussion. So we approached this two ways. The first was that we took a look at a gap analysis on the topic, and then we did some observations on how to address these particular gaps. When we did the gap analysis and we were looking at these differences in evidentiary requirements and other strategies, we broke them into a couple of broad categories, and for sake of convenience, I've combined them into a couple. The one being what we called universal and general issues. So within those, we recognize that there's this kind of growing requirement for what we call minimal proportional representation of local patients in MRCTs. I think you've all faced that. We talked about this morning. I guess there was a little bit of a discussion around this, whether or not there was a country bias here. Was there a reason for this? Was it political? Did this help build a clinical infrastructure? Was there maybe a lack of trust among certain regulators, not trusting other people's data and therefore wanting data from their own population, or was it truly a scientific reason? In some cases, we didn't think that there was a scientific rationale for the exact proportional representation that was being requested. We found that there were inconsistent ethical oversights, and this was going to be a complication across regions when starting clinical studies. We realized that we needed to address the influence of local standards of care in clinical practice. This is a big issue when it comes to actually trying to identify these evidentiary requirements. With regard to just overall GXP, we covered a variety of these, but just to summarize, to say that because of the inconsistencies across jurisdictions with GXPs, we thought that those were a particular barrier to coming across appropriate evidentiary standards. And finally, we talked about the issue of benefit risk and the local tolerance for the benefit risk profile, and how risk tolerance can vary by region. And I'll come back to that because that was a germane component of our conversation. So I talked about those general issues. We also talked about disease-specific issues. And for instance, we talked about if you were to start a study in rheumatoid arthritis, whether or not the appropriate controls were available in a particular region or jurisdiction. Standards of care differ, so for asthma trials, they can add a complication in trying to identify the evidentiary standards. We realize that this has an implication then on study designs, and without going into the details there, we recognize that when local data requirements differed, then endpoints and comparators had to be adjusted, and this complicated issues. But what it seemed to come back to was, and I think there was good agreement in our group, was that we needed to align on the patient needs, patient-focused outcomes, and that PROs and other data that are relevant to the real world is going to be important in identifying evidentiary standards. So we recognize that the relevance of these standards to some regulators for their initial decision is still complicated, and that we would need to work through that. So how can we address these gaps? The big issue that we realized was that we needed a way of communicating benefit and risks. That was really the linchpin to our conversations. So we wanted to know, is there a global or a local decision being made to benefit risk for the assessment of a medicine? And obviously, the decision is context dependent, and it needs to be somewhat local. So if the assessment approach can be standardized and the limits identified as to what and what cannot be aligned or harmonized within the approach, then we think that that can lead to an effective, transparent communication methodology. So we talked about the FDA's approach, the EMA's approach, CRS's approach, a number of other approaches, and how these are bringing continuity to a standard decision process. So the most we thought one could ask for is transparency around how a decision is made and the uncertainty around the factors that led to that particular decision. We talked a little bit about how to get around some of these issues in ICH regions and non-ICH regions. And just for brevity, I'm going to focus on the non-ICH regions. And we talked about a couple of different approaches. One certainly that was touched on this morning is this concept of capacity building, especially in making good benefit risk assessments. How do we help the less mature agencies make these decisions. And we thought that perhaps we were talking that being helped by ICH countries is certainly one way of bringing expertise into the less skilled agencies. Having the right benefit risk tools, that's going to be the key to this whole discussion in order to provide a simple, structured, and systematic approach to decision making, and especially within the smaller agencies. But I'll come back to another aspect of this that's a little trickier. Part of this is that we need to create a common lexicon and a common format for benefit communications. So if we have these common structures for benefit communications and risk communications, then they could be better integrated into things like Section 2.54, the benefit risk section within the CTD. So we've been talking about how we might actually more formalize these approaches, and we talked about some of the recent examples of FDA's use of their benefit risk approach and how that's appeared now in reviews on the web. The good thing about a benefit risk approach that's well structured and facilitates communication is that it can be used by different stakeholders. So it can be used by the developers, obviously during the development process. It helps the developers then have interactions with agencies like at EOP2 meetings, helps communicate decisions to patients, and even at AdComs. And just to sort of finish up, some other ideas that came up was this concept of looking at harmonized guidances that might be issued by disease state. Now, we talked about this, that if there's global acceptance of these guidelines, it may lead to more transparency about how to conduct clinical trials. But then it was brought to our attention that this was actually tried before, kind of ran into a brick wall, and maybe now is the time to reconsider this, but maybe not. So then we said, well, what about non-ICH guidances? Could there be a way of assessing where they are, what they are? We're told there were many of these floating around, and see whether or not there is any global use for these. Coming back to benefit risk, we did think that there needs to be more beta testing of benefit risk tools and learning from the mature agencies. And then in conclusion, really coming back to this concept of information sharing. That's really what our whole discussion was about, was if one can communicate well, then understanding the particular needs and how to then interpret the evidentiary standards falls into place. So for a smaller agency, being able to access information such as the information from a CTD or even an EPAR or an SBA or pre-qualification summary, this forces a systematic thinking by the small agency about the benefits and risks. And then if they can write down their ideas of benefits and risks, then they can communicate how they made a decision. So we realized that there can be problems. For instance, if one agency withdraws a product from the market, but an agency leaves it on, for a smaller agency, it may be difficult then to understand what the relevance is for their particular population. So at the end of the day, it still is a local decision, but has to be informed by global information. But we also realize that in order for all this to happen, you need one thing that isn't necessarily available worldwide, and that's a good IT infrastructure. We were talking about downloading these documents, but in some countries, actually downloading a PDF might take 5 minutes. So it could delay a review if actually the IT infrastructure isn't there. So in summary, I'd like to say that we had a very good discussion of a wide-ranging set of topics, but I think they all come back to one concept, and that's good communication. Thanks.
Great. As Lauren sits down, are there any questions of clarification about that session?
Again, Toshi Tominaga, Osaka University, Japan. As to the benefit risk analysis and the communication, so the benefits and the risks are delineated, probably weighted, and then make a decision. And then, the ground, how did you think about, how did you make the decision? Is communicated. That is the process. Or benefit and risks are weighted and quantified, and plus and minus. Benefit minus risk is minus 3.0. Therefore, this is, which is the case? Delineation and the communication, or the calculation benefit and risk.
Right. I don't want to turn this into a benefit risk assessment session. There are obviously various ways of addressing this, and we didn't go into the details of whether to use a quantitative, a semi-quantitative, or a qualitative methodology. We talked about the way that the FDA has approached this, for instance, and how uncertainty around various elements of benefits and risks can be described very, very clearly. regardless of the tool, and we talked about this, the idea is that a well-structured tool that follows kind of a common approach, a common framework approach, allows then communication between stakeholders. So whether you decide that you want to rate by a +2 or +3 or +4, or someone just says, ordinarily, I think this is more important than this, at least there's a basis for communication. And for many of the smaller agencies that need to make a local benefit risk decision, and I'm talking about non-ICH agencies, just the simple act of formalizing their ideas, stating what they think are the benefits for their population and the risks for their population and why they came to those conclusions is sufficient for them to then communicate to other stakeholders within their country and even with other agencies. Yeah.
I will then go to Leslie to talk about the feedback from the clinical development breakout group.